Let's finish up with a few other targeted therapies that I think we're all excited about. Let me just mention the IDH1 inhibitor, ivosidenib, also known as AG120, in single agent, phase 1, phase 2 data. Remarkably similar data as we've seen with enasidenib in the relapse refractory IDH2 mutated. These are IDH1 mutated, a little less frequent, 20% CR rate, overall response rate 40 to 50%. Some deep remissions have been seen, including clearance of the clone, differentiation syndrome being probably the
very similar.
Very similar. Okay. How about venetoclax, Jorge?
Well, venetoclax, a BCL2 inhibitor that's, of course, we know it in CLL, effective, very and well tolerated once we figure out that the scheduling at the beginning to eliminate the tumor lysis syndrome issue. And there's always been interest in BCL2 in AML because it's always present, probably overexpressed in many instances. There was many years ago these oligonucleotide, and there was high hope for that, and it ended up dying. And I remember there was some, I don't remember what, a company that was working on apoptosis, and they developed this clever thing that said keep apoptosis alive, and I'm glad we did, because eventually we figured out these venetoclax, and the data that has been generated, particularly in combination with hypomethylating agents and also with low-dose RRC, has been quite impressive. I mean, the response rate is these are older patients, is in the upper 70% range. Of course, we want the control trials, and we want, but it looks pretty impressive.
I agree. I think it's very impressive data. The CR rate, the overall response rates are very high, but let's be cautious. We've seen overall response rates very high. For example, vadetuximab with azacitidine, the anti-CD33 antibody. We need to see that it translates into a survival benefit. We need to make sure it's tolerable in these patients. I'm going to move on to Eunice. There's this class of drugs, E-selectin inhibitors, and one that's moving along in clinical development.
Right, so this goes back to your original question about the microenvironment, the importance of the microenvironment. So we know that the leukemic stem cells stay within these specific marrow niches, and they have very close relationships with the endothelial and mesenchymal cells that are in the bone marrow microenvironment. And just by taking a leukemic cell and attaching it in even a culture dish to endothelial cells or mesenchymal cells, just by having them physically interact, there are ligands that are triggered and factors that are released that allow that to be inherently chemoresistant. And when you add the chemotherapy, the cells just don't die, okay? So what this E-selectin agent is it's going in, and it's a 1-hour infusion that you give 1 or 2 days prior to chemotherapy, a couple days after chemotherapy, as well as during and through the chemo. And what it is doing, it is blocking that very specific therapy-related mediated interaction between the leukemic cell and the microenvironment. By cutting off that E-selectin, which is a key adhesion molecule, those cells cannot adhere, and so they are in suspension, and so say. And then when they are in suspension, they don't have the protective mechanisms, they don't have the activated pathways that promote survival in that setting, and when they get exposed to the chemotherapy, the hypothesis is that they die. So the exposure to selectin inhibition prior to, during, and after chemotherapy is been hypothesized to render those cells inherently more sensitive to the baseline chemotherapy. And the results of the initial trials presented here by Dan D'Angelo at this particular Congress show pretty impressive results, both in relapse refractory AML patients getting salvage chemotherapy, as well as in a subset of older patients as well, that were fit enough for standard chemotherapy, with impressive or very convincing response rates in those difficult to treat patient populations. I mean, this is a drug that when the FDA reviewed the data, they thought that this particular drug, whether it's a mechanistic thing or just the lack of toxicity that they saw, they granted this drug a breakthrough approval. And the benefit of it is that some of these patients were getting etoposide, which is a mucosal damaging agent, and there is data, preclinical data, that in addition to allowing the leukemia cells to be more sensitive, that it actually can decrease mucositis because it has effects in that region on the microenvironment.
Well, wearing my SWOG leukemia chair hat, one of the things I'm really excited about is a partnership between the NCI and the sponsor of this drug, moving it into a phase 3 study in older patients who are fit for chemotherapy, comparing 7 and 3 versus 7 and 3 with this E-selectin inhibitor, GMI 1271. This study's been approved by the Leukemia Steering Committee, so hopefully it'll be a study that our patients can be registered on next year.